Can you hear me?
Oh, yeah. Hey, that's
Okay.
great.
Great.
Thanks so much.
Great. Great. Can you see the slide set?
Yes, we can.
Okay, and me as well? So the slide set is more important than seeing me. Okay. Excellent. Well, great. I'm really happy to be here, and the quarterly board meetings are the only kind of thing that would have kept me away. But it's really great to be a part of this panel, and it's actually very exciting because what I'm presenting today on the overall action framework and the measures, we got the final total thumbs up from the board just yesterday to remove the kind of in discussion status to full launch status of this report. So this is the first time I can present this without any caveats that our board are still refining some of this and discussing some of this. So it's an exciting time for us and a great opportunity to share this with you today. It's really great to follow Steve's great primer on measurement, and really much of what I'm going to be sharing builds on the constructs he introduced and the challenges and opportunities with developing measures to track really such broad conceptualizations of health. So I'll share our process about how we got to these culture of health measures, and particular emphasis on the framework we developed for the national measures that were selected, because the framework is also our whole foundation strategic framework for all the work that we do. But we believe that the framework and measures are also a kind of a catalyst for the national movement to build a culture of health, which is obviously broader than our specific grant-making activities. So I'll both give you some background on how we developed the action framework, go through some of how we selected the culture of health national measures. I'll spend some time talking about the synergies and complementarity of our measures with other metric sets, some of which Steve mentioned, but I'll go into a little more detail about the complementarity to the IOM Vital Signs report, a little bit about what we'll be doing later in the year in a community-based and a proof of concept called our Sentinel community studies, and then be part of the Q&A after the next presentation. So as David said, we've been working on this really over the last couple of years. And I want to acknowledge the deep collaboration with RAND on all of the development of this work, who continue to be a key partner in the research that we underlies this model. We really started this out with really one question, driven from the 10 principles of building a culture of health that RISA and the board had promulgated in the year before. So from the research side, we really started our scan and our analysis with the big question: what's holding us back as a nation from the health status and health equity we aspire to? The two subsets being, what do we know a lot about that's fairly evidence-based that we don't take the scale, and what do we really need to know more about? And so that was really the set of driving questions and the whole enterprise, with a particular attention given what we know about the social determinants of health, the corollary of that being that many of the assets, or perhaps most of the assets, that would drive and change those determinants are outside of the health and healthcare system. How do we develop a set of measures and a framework which really engages those non-health sectors in an evidence-based way, but one that shows them the handles and the bridges so that their activities connect with those of us in health. As you heard from Steve, it's really critical to develop a set of measures that are compelling and catalytic, and that's what we've tried to do over the last few months. And you can see from the timeline much engagement, multiple meetings with leadership at CDC, NIH, formal content analysis and focus groups with 13 communities around the country. RAND provided exhaustive literature surveys, really a lot of stakeholder engagement. We did a soft launch of what I'm presenting in Washington, D.C. on May 28th. Some of you may be in attendance, have been in attendance there. And after that, this has gone out to the report to about 2,000 different people. We've got surveys about that. We've been moderating that all along. We've been trying to make sure this engages many different perspectives, political perspectives. And I want to emphasize sort of the engagement behind the model, and I want to also emphasize the evidence base that we're building is really an evidence base around things that we can motivate, improvements in health, more convincingly defined, but improvement in well-being and the kind of partnerships that lead to well-being, which are a little different than some of the metric sets that Steve talked about. So this is the Culture of Health Action framework we developed. And again, the framework was critical to the development of the measures. And I think the research that we did with RAND really showed, and if there's anything that we think is the primary communication we're trying to do with this is that this framework really represents 4 areas and an outcome area that we believe, and I believe the evidence supports, that if we either knew more about these areas or implemented things that we do know, this would allow us to build this culture of health over a significant period of time. And I'll just make note that as far as the Robert Wood Johnson Foundation's commitment to this is a 20-year commitment by the board, because these are the kinds of population health and systems changes that are certainly not going to happen overnight and really involves the interdependence of many social, economic, physical, environment, even spiritual factors affecting health and well-being. I'm just going to quickly go over each of these areas, and I've learned in other presentations it is absolutely impossible to give a slide presentation on 41 separate measures, so I will be highlighting some of the 41 measures that fall within these action areas. I'll start with action area number 1, making health a shared value. Comes out of some of the things we were saying in the foundation of that we need as a nation to see that we are all in this together. And it's a very interesting area, and as you see from the measures we developed, one where we need to know more about what it takes to make all the residents in this country think about health and well-being as much more than the absence of illness, and affirm health in daily choices and local policies that also affirm health. So you'll see that there are a number of drivers and measures in that area are really around to that end. Fostering collaboration, cross-sector collaboration, a major thrust of the foundation. I'll talk about it, and a kind of new set of measures that are really trying to incentivize and measure progress in the kinds of cross-sectoral collaborations required to improve health and well-being. The third action area, I think, just quickly, is all the work many of us have been doing with creating equitable and healthy communities so that no matter what your zip code is, you have an equal probability of having a good healthcare outcome. And certainly action area 4, strengthening integration of health services and systems, work we've all been involved in with increasing value, driving more toward prevention and understanding how even we can put more investment on the social side. So I'll come back to this with a few examples of the drivers within each action area and a little sampling of some of the measures a little bit later in the presentation. And I think, Steve really covered a lot of the kind of theory of how you try to construct a compelling set of measures. So we have 41 measures that we selected. I really only wanted 30, but we've got 41. And they were selected, right, it's a prime number at least, that's kind of nice. But if the 41 measures were selected as national measures based, again, on some of the things on this slide, availability of national data, either available or we could construct it through a survey, and you'll see how we did that. We wanted to make sure that our measures were applicable across the lifespan and health span. In some of the early presentations on this, when you have a overriding concept like the culture of health, lots of comments from like the disability community. If you have a chronic condition, can you be in the culture of health? The answer is absolutely yes. So we had to make sure that we were talking about health in that way. Broad determinants and upstream drivers. If there's anything that was driving our conceptualization of the framework and the measures, it's what do we do to actualize all of what we've learned about the social determinants of health in a way, and this goes to point 4, appeals to multiple audiences, because I think all of us on the healthcare side understand those determinants, but I think we have much more work to do to bridge to other audiences who actually have those assets that they can put in play to do that. And then equity, I'll keep coming back to equity. If there's a key outcome we are trying to achieve in all of our work at the Foundation and hope to catalyze through these set of national measures, it's just achieving health equity in this country. So there's that overarching concern with equity in all of what we're trying to do. So let me go back to that very important, but really probably most difficult to measure area in the action framework, which is making health a shared value, And in each of these, in developing the frameworks and doing the research to support this, we determined in 3 drivers that we felt changes in those areas would be important to moving that action area. And then there were measures that we selected that we thought were as best as we could do in the framework we had for the 1.0 version, measures that would be reasonable indicators and incentives to move in these areas. So again, in this area, mindset and expectations to capture how the views and expectations we have about health inform the decisions that we make as individuals, community, as a nation. The civic engagement to reflect whether Americans feel motivated and able to raise their voices to make a difference, and this sense of community to gauge the extent to which individuals feel their health is interdependent with the health of others in their community. So these are the major drivers. I hope you got the handout of the actual 41 measures, because it's hard to see as a slide. If you didn't, I'll make sure that you get it later. So we think it's a really critical area of building a culture of health. The board spent a lot of time on this one actually this week, that some of the changes we're trying to incentivize really require a gestalt shift in the way people think about health. So we're invested in this area, as you'll see later in the talk, of providing new research grant opportunities, really to explore how we can understand this area more clearly. One of the measures that I'll mention in this area, this percentage of respondents who identified strong agreement that their health is influenced by peers, neighborhood, and broader community. This is from some new data that we're getting from the RAND American Life Panel, Culture of Health Survey, but it's a measure that is actually a validated measure that comes out of David Chavez's work on social cohesion. So this is an example of one of the measures that we think is important that we would like to improve over the course of these 20 years, and individuals in their community understand the community nature of improving health. Fostering cross-sector collaboration to improve well-being. You'll see that we will be using health and well-being somewhat interchangeably. We found in the work and the stakeholder engagement work that many sectors who aren't traditionally in health really respond to well-being in a more actionable way than when you sometimes define this just as health. So just quickly through these drivers, enumeration and quality of partnerships. We really want to gauge the extent to which meaningful relationships are built to catalyze change. Resource investments across sector. These are a set of measures to track the quality and quantity of corporate and federal investments in collaboration. Are there money and resources put where partnership rhetoric is? And then policies that support collaboration, to highlight policies in kind of a health and all policy sense that have the potential to catalyze widespread improvement in health and well-being. The measure I pulled out here, which a year and a half ago we thought would be very controversial, but now, because of the unfortunate prevalence of the occurrences across the country, which shows what happens when you do not have a significant level of training of police and community relations and sufficient trust and engagement between police and communities. This measure that we've gotten from the Bureau of Justice Statistics, percent of full-time sworn personnel who have served as community policing or community relations officers or designated to engage in those activities. This is an example of a kind of collaborative measure between police, communities, public health that we believe is a very important indicator of necessary cross-sector collaboration to improve well-being. So we have a number of other measures in that area on collaboration, one of which we've developed with the American Hospital Association out of their annual CEO survey to look at the increasing prevalence of sustainable and high-value hospital community partnerships that go beyond sort of the IRS minimum requirements. But this is an area, I think, that is not overlapping with a lot of the other measurement systems, but we think it's really important to the way we think change will happen, and it's pretty closely aligned with a lot of our grant-making activities and the partnerships that we are trying to catalyze. The third action area, increasing healthier, more equitable communities. Again, all of us have been working in this area for a long time. It's certainly part of what the foundation has been doing. And then the drivers in this area, I think, are ones that are pretty well known. Improving the built environment and physical conditions for well-being, recognizing that the social and economic environment in communities and neighborhoods is equally critical, and then really trying to gauge the impact of policy and governance changes that can support healthier, more equitable communities. So we have a number of measures in those areas. I just pointed out this one from the NIDA, the Monitoring the Future survey, percentage of middle school and high school students feeling essentially safe in their neighborhood. When the full report comes out, you'll see that that's a measure right now that shows significant race-ethnic disparities in that percentage of students feeling safe. And like a lot of the other measures, these are measures that are kind of a windows into actions that would bring sectors together to make a difference. So it's a measure of an issue, of a problem, but it's also a measure that speaks to the kind of engagement that we want to get to resolve that problem. The fourth area, strengthening the integration of health and healthcare services. I think that if you've got the measure sheet in front of you, some fairly conventional access measures across a number of different kinds of access to healthcare, dental care. So that's a very important part of that. But it goes beyond just coverage. The consumer experience and quality, very important to understand efforts underway to improve the patient experience in the delivery system. And then the very important one on balance and integration driver, initiate a better balance of preventive and acute services, and particularly integration of social services in the continuum and in the light of some of the book that Betsy Bradley wrote and others are talking about in terms of the rebalancing. I lifted up the measure here that we have, the national measure as best as we could do on the percentage of populations whose healthcare provider is part of an ACO, with the full recognition that this is like a placeholder category for what we're calling value-based preventive-oriented care, and that there is a little noise in the system at the definitional level, but we've picked the best one, and it's an example of a measure we're trying to refine by the 2.0 version, but it's a very important metric around trying to look at this very important systems change, which can address, we think, a number of population improvement goals. And then finally, in our measurement system, and it's in the middle of that action area model that I started the presentation with, 20 years of work on this broad intersectoral collaboration, well beyond just what we do at the foundation. We would hope that we would have these longer term changes in those outcomes. And we've included that in the model. The drivers are well-being, chronic disease management, and adverse experiences and cost. And so, we've got measures in all those areas. We've looked at disability-adjusted years for chronic disease burden. We've looked at, we have measures around decreasing adverse child events, and we have measures on both end-of-life cost and total family out-of-pocket cost on the cost side. On the well-being side, we draw on some measures more commonly used in some other countries, but there are well-being indices that compare us to those other countries, and so those are the longer-term measures. And then just a measure I lifted up here is the annual the one on end-of-life care as just one of the kinds of measures we're using to kind of incentivize action in those areas. So that's our framework, and let me just talk about its synergy with other measures. And again, I mean, Steve really did a comprehensive assessment of all of those. So I think we intentionally didn't duplicate, tried to complement all of those existing measures, but I put particular attention to our sister set of measures at County Health Rankings and Roadmap, and I know you'll get a presentation on that. Both very important measurement systems that the foundation is associated with. Julie will tell you more about the latter one. I think the key distinction between the sets on culture of health measures are really designed to gauge national progress and in non-ranking and a non-index way. The measures were developed to suggest specific action-packed ways and really engage these broader sector partnerships, but there are many things where they connect. For example, we've included a measure on the number of states with expanded practice laws for nurse practitioners in the national measures, which really catalyze the action to improve access to health care, which the rankings track. So we think there's a good synergy between those. So I wanted to spend a little more time with this significant synergy between the vital signs domains and the culture of health action areas. And this is just an attempt to kind of match the vital sign domain, the kind of names that go around the circle of that model, and our 4 action frameworks. And we see quite a bit of similarity between the domains of where we believe we need measures that matter. Health as a shared value is certainly equivalent to engaging people, creating healthier and more equitable communities, healthy people, strengthening integration of health services and system really relate to care, quality, and lower cost. And our long outcome measure, improved population health, equity, and well-being, also relates to the domains in vital signs. And if you're interested, we also have a crosswalk where we actually crosswalk our 41 measures to the vital signs report. And if you have that handbook on the 41 specific measures, you can see that we've really tried to, particularly in Action Area 1, look at some potential measures to understand how engaged people are in health, even through social media analysis, our Twitter measure, and a lot of measures that really try to, across our framework around to provide a good sense of where we are on healthier communities and better collaboration in health and healthcare. So we think that it's really important to see that synergy. And again, the distinction, we've gone a little bit longer and more deeply into the multi-sectoral partnership strategy, and which we're finding to be a really powerful way to move this work through partnerships we had never had before, like with the Federal Reserve and community developers to develop affordable housing and get at some of the residential segregation issues. So with the partnership with the National YMCA, United Way, these partnership strategies seem to be really critical in really leveraging this culture of health, and we need some kind of indicators for that. I'm kind of bringing this to close now. Again, when you're developing a national metric system, the real question, particularly for those of us like myself who spent most of our career in local public health, health happens locally. So how do you understand whether the measures, the dynamics, the action areas that we have posited really make sense and reflect effective collective action to improve health and well-being at a local level? So we will be launching at the big national launch of this whole thing, which is going to be at APHA this fall in Chicago, our Sentinel community study. And again, this is not a big place-based strategy. It's Sentinel, kind of in the epidemiologic term, where we really want to understand the evolution of collective action for health in all of its varieties, regional, north-south, different demographic mix, not just best practices, but really practices that show where communities at very different levels, how they got there, where they're going, with the goal of being able to identify some clusters within those that can lift up strategies, approaches, local measurements that seem to be effective in developing collective action for health. So we have a broad definition of communities in this. We will have some small states. We will have some tribal nations. We will have varieties of rural communities, and they will represent different parts of the country. And we'll be collecting kind of a minimum data set between all of those. We will have a real mixed methodology. We're working with the University of Chicago to do what's called a kind of a sentiment analysis to typologize all these areas and the way people think about what generates health, what they think about market versus governmental forces, and in that kind of mixed method approach, lift up these stories and examples and data about how these very different communities try to build a culture of health and the role that measures and metrics play in that. We'll lift that data up in a new website, which we're also launching at APHA, cultureofhealth.org, where we'll be migrating a lot of our data-oriented, research-oriented work going forward from the foundation. We'll have many other community projects that we're funding that are more programmatic around the country, but these 30 communities are really Sentinel. We're not providing a lot of technical assistance. We really want to see what they're doing. So you can look forward to that. I'll end with the fact that, when you have a strategy, I think as bold as ours, and some of the measures that are not conventional measures in the way we've looked at health metrics, we are simultaneously trying to build the evidence base for this approach. And I just wanted to mention that we have 3 new research programs that are launched or are being launched over the next few months to really build this evidence base for the culture of health. And it's 3 programs, one called Evidence for Action, Policy for Action, and Systems for Action. And this emphasis on action is really to emphasize the imperative of the translational function, deep translational function of all the research we're doing, so that it is meaningful and engages the sectors that need to use that information to build this culture of health. So we would encourage all of you to be on the lookout for those. Evidence for Action has a rolling application period already launched from its National Program Office at UCSF, and Policies for Action, which is a change in development from the Health Policy Law Program at Temple, will be launching soon. That's really to build what I would call the science of health in all policies. And then Systems for Action is an evolution of Glenn May's good work at Kentucky, which will broaden from research focused just primarily on public health systems to research on the integration of those public health systems and collaborations with other systems to improve health and well-being. So again, those are our measures. They are really characterizing, the framework rather, is really characterizing where this foundation has aligned all of its resources going forward to try to build this culture of health. That doesn't mean that we will be working intently on each of these 41 measurement areas, but we are definitely organized around the action area and those drivers. We'll be putting out a 2.0 version of these measures late 2016 and using the website and all other kinds of engagement strategies to get comments on how we might improve this set as we go forward. So I'll end there.
Alonzo, thank you so much for that. And I guess I'd just say personally, I really want to express gratitude to you and the foundation for the energy and creativity that you've put into this really groundbreaking work, and the fact that the foundation is committing to it for 20 years is really amazing, and we look to a lot more to come for our field. And I assume, Alonzo, you'll be able to stay with us later for the question period. We don't have hard copies of the 41 measures, but they will be put up on our website of this workshop right away after the meeting.
Great.
Okay, now our third opening panelist. Happy to introduce Rajiv Bhatia, who's the executive director of the Civic Engine. as we were thinking about this, some of the metric sets that that Steve talked about or that are profiled in the back of your book are sort of the traditional ones with traditional public health and healthcare metrics. Some of the sets reach into some of the health and all policies and the other social determinants, but not very robustly. But there's so many, like housing and education and transportation, economic development. What could you do in a summary way? I'm sort of a metrics person, but I really did not know about the metric set that Rajiv is going to discuss for us that HUD pulled together a few years ago. And so it's a nice summary way to touch into some of those non-public health and healthcare metrics. So Rajiv, over to you.
Thanks.